Committee on Health. Item number 4, AB 266, and item number 5, AB 374, are going to not be heard today. We have one consent item. Item number 8. Once we establish a quorum, we will go ahead and move on those issues. Otherwise, Mullen, I see Assembly Member Mullen, number 1, AB 50, Medi-Cal evidence-based home visiting programs. Good morning, good afternoon, and welcome.
Good afternoon, Mr. Chair and Senators. Here to present AB 50. With rising healthcare costs and an increasing Medi-Cal eligible population across California, there is a need to strengthen the capacity of our current healthcare system to address the health needs of our most vulnerable populations at lower costs. Evidence-based home visiting programs are proven health-based programs that can improve the health of low-income families in the state while helping reduce overall costs to our healthcare system. With more than 3 decades of evidence from randomized controlled trials, evidence-based home visiting programs have demonstrated sustained improvements in maternal health, child health, positive parenting practices, child development, and school readiness, reductions in child maltreatment, family economic self-sufficiency, linkages and referrals, and reductions as well in family violence. Evidence-based home visiting programs have specifically demonstrated reductions in preterm births, preventable maternal mortality, complications of pregnancy, closely spaced subsequent births, childhood injuries resulting in costly emergency department use, and hospitalizations. This bill, AB 50, would require the State Department of Healthcare Services, in consultation with stakeholders, to develop a plan on or before January 1st, 2017 to ensure that evidence-based home visiting programs are offered and provided to Medi-Cal eligible pregnant and parenting women. With me today, Maria Camargo and Brian Wagner from Nurse Family Partnership to answer any technical questions you have, and I respectfully ask for an aye vote.
Thank you. Anyone like to speak in support of the measure? Please state your name and your position.
Hello. Am I being heard?
You are being heard.
Chairman Hernandez and honorable members of the Senate Health Committee, I come today as a pediatrician and public health official, the former state health officer and director of the Department of Public Health, to express my full support of Assembly Bill 50, the Nurse Home Visiting Programs Bill. The problem: California's many low-income first-time moms experience poor health outcomes for themselves and their babies and rely heavily on publicly funded health and social support programs. The solution: evidence-based nurse home visiting programs provide the in-home support families need to improve their health outcomes and reduce their dependency on publicly funded health and social safety net programs. More than 3 decades of peer-reviewed evaluation research on the Nurse Family Partnership Program, a voluntary nurse home visiting program, demonstrate conclusively that the in-home support of a nurse during pregnancy and through the child's first 2 years helps first-time moms efficiently navigate the health system, have healthier pregnancies and with improved birth outcomes, provide a healthier first start for their babies, and become more economically self-sufficient. So how are we doing here in California? In California, about half of all births are to mothers covered by the Medicaid program. About 40% of those births are to first-time mothers. That's roughly 100,000 mothers and newborns that could potentially benefit from nurse home visiting every year. 21 counties in California have already implemented voluntary evidence-based nurse home visiting programs. A total of 3,650 mother-child parents are currently enrolled in those programs. With the support of their nurses, many of these mothers have finished their education, obtained stable jobs, left abusive relationships, and eliminated risky behaviors to become the best mothers they can be. Their children are healthier, better prepared for school, have higher academic achievement, are less likely to suffer from mental health and behavior problems, or get involved in crime. But with less than 5% of potentially eligible moms currently enrolled, we've barely begun to realize the program's huge health and social benefits. At a time when Medi-Cal enrollment continues to increase, it's important that we connect Medi-Cal eligible moms with nurse home visiting programs that can improve their health and reduce Medi-Cal expenditures. So what does AB 50 do? The bill, importantly, would not create a new publicly funded entitlement program. The counties that have already implemented the program here in California have come up with a variety of creative ways to fund and implement the program. This bill would simply direct the Department of Healthcare Services, working with community partners, to develop and implement a plan to make voluntary nurse home visiting programs accessible to all eligible first-time moms in our California communities. I urge you to give AB 50 consideration. Your support for this bill will result in significant improvements in the health and social well-being of California's many low-income first-time moms and their families, reducing their dependence on health and social safety net programs. Thank you for your attention. And vote for AB 50.
Thank you. Anyone else like to speak in support?
Good afternoon. My name is Angela Rothermel. I'm here representing Children Now, and I'd like to thank the author for bringing this bill forward. And this is a very important issue for my organization. We see it as really cross-cutting, and especially for the infant and toddler population that is not receiving as many support services through child care and preschool investments. This is a great way to bridge that gap. Home visiting programs match expectant and new parents with trained professionals who provide family-centered coaching, education, and support on an individual basis. These voluntary programs reinforce parents' own efforts to provide the best possible foundation for their children's health and learning. Home visiting programs are proven to promote families' economic self-sufficiency, foster healthy child development, and positive parenting practices. Home visiting programs can yield as much as $5.70 in returns for each dollar invested. For instance, mothers who received home visits during pregnancy were nearly half as likely to deliver low birth weight babies, saving up to $40,000 for each averted low weight birth. If California reduced its current low birth weight by half, the state could save as much as $673 million per year. We believe that this bill can help California cost-effectively promote children's well-being and enhance the impacts of the Medi-Cal system. California should be one of the 20-plus states that have established plans and mechanisms to draw down federal Medicaid dollars and leverage other resources in order to implement evidence-based home visiting programs at scale and enrich comprehensive maternal and child health care. We urge an aye vote. Thank you.
Thank you. We have about a minute left for testimony. Please state your name, position.
Beth Helmson with Fight Crime Investing Kids, representing over 400 sheriffs, police chiefs, and district attorneys in strong support.
Maria Camargo with Nurse Family Partnership, and we're in strong support.
Jasmine Gordon on behalf of the California Black Health Network in support.
Alex Hawthorne on behalf of March of Dimes and San Mateo County in support.
Thank you. Any opposition? Questions from any of the members? Senator Nielsen.
Thank you. Doctor, one of the key elements is the empowerment of the parent. And do these programs that we're referencing in the bill, do they help identify where the parents can have more authority, more responsibility for themselves and their families, the self-esteem aspect of it?
Absolutely. I've experienced with the program, and the whole goal here is to make the parent more self-sufficient in many ways, both in terms of their ability to competently, raise and foster their children, and in terms of their interaction with, publicly funded social and health support programs to make them more likely to be able to complete their education, get a job, and support themselves. So that's this idea of self-empowerment is very important.
That was one of the aspects long ago of what was called the GAIN program, which later became CalWorks. And one of the fundamental elements of GAIN, which then changed into CalWorks later, was that we needed to get an education. And that was going to be part of being in the CalWorks program. If you were going to be a part of, or GAIN rather at the time, then we were going to not guarantee you a job, not simply provide for your family, but we were going to develop within you employability. And part of that was education. And part of that was linked to child care for the mother or the parent when they were involved. Now, one of the elements that I'm thinking about geographics. We're talking about a lot of the negative forces that make problems for families, for mothers and fathers. But part of it is socioeconomic level, but part of it is just the geography, where you're at. To me, then, that implies what do we do, not just about the individual families home visiting, but what do we do about the entirety of the community? Is that somewhat addressed in the concepts here?
Traditionally, nurses that are involved with these kinds of programs are very in touch with what's going on in the broader community. And I think that you can count on the fact that if this program is implemented, that this will help the nurse deal with the family in the context of the broader community. Are they an impoverished community? What are the transportation modalities available to them? What are the various businesses and social services available to them in the community? So all those things. Can they walk their kids? Can they play with their kids outside? Those are the kinds of things that nurses are uniquely capable of making the connection between how the family is working and in the broader context in the community in which they're living.
The support of the police here is very significant. I'm very knowledgeable of this particular area. And in all of my dealings with criminal offenders, it's a very sad state. I have no studies to corroborate this assumption, but I would say, based on pretty vast experience dealing with everybody from first-time parole violators to death row inmates, that 90% or more have what I call the broken heart, that they were not nurtured, cared for, and because of that wounded heart, they drifted off into bad things. And one of the failures of the California Youth Authority of years ago had all kinds of programs, but they did not have programs, I found, that dealt with the broken heart. That really is an important thing. That's kind of what I talk about in terms of environment, and that's why the police see this. There's even a theory, the broken-winded theory, early intervention. And I gather that's a part of the program that you're suggesting here.
Absolutely.
Lastly, it will require some funding. What might be some other 501c3 type sources, or what would be contemplated as possible fundings?
One of the interesting things that's being explored for this program is the concept of social impact investments. In other words, bringing a whole range of new venture capitalist types of organizations to the issues of social welfare, with the idea that if certain programs like the Nurse Family Partnership Program is implemented, we can count on the fact that there are going to be savings to health and social services, and that it is worthy of an investment that will accrue to some payback. So that's at least one mechanism that I know that's being looked at for alternate ways of funding, this kind of a program.
Well, I am endorsing your concept of looking to other ways. The general fund in the future will not be the best place to go in California. So
absolutely. To the extent that the Medicaid program is going to accrue benefits, we would expect that the Medicaid would support the program financially, but not a blank check. Once again, this is not a new publicly funded entitlement program. This is we want the partners that are going to benefit from implementing the program to help support the program.
And a lot of the concepts have been around and employed in a lot of ways. And we're talking about evidence-based. I gather you're saying that you're basing it on some of the things that we've done in the past that didn't work. Right? There have been many.
Dr. David Olds is internationally known now. He's the one that was the brain behind this program and has designed very rigorous evaluations in a number of different contexts in different types of communities across the country. This is probably one of the best evidence-based, best proven evidence-based program in public health.
Very good. Ma'am, you had something.
Yes, I was just going to add that the bill contains a very rigorous definition of evidence-based, so it's not simply, programs that have one or two studies, but actually programs that are very, very well researched and have demonstrated outcomes across a number of child and maternal domains. So including those like, as the doctor was referencing, like increased education and employment of mothers, but also increased developmental outcomes for children and reduced special education and crime costs in later years. So there's a very, very high bar that we're setting with regard to the evidence of these programs in order to be able to fulfill the promise that we're making about returns.
Thank you. Thank you, Mr. Chairman.
Please, Senator Pan.
Well, thank you so very much, and Senator Mullen, thank you so much for bringing this bill forward. We actually want to recognize the work of the first 5 commissions in home visitation, which has really paved the way here in California. Many of the first 5 commissions did fund home visitation programs. I was proud to help host the town hall here in the Capitol, where we present the evidence with First 5 LA and presenting a very robust basis of evidence supporting home visitation. I would also make note that I'm proud to good friend Senator Nielsen. One of the big impacts of home visitation is that oftentimes families with young children, new families, are somewhat socially isolated for a variety of different reasons, particularly disadvantage, and that we may have resources out in the community from nonprofits, from government, from other sources, but if all of us who've ever been new parents, sometimes it's hard to figure out where they all are and which are the good ones and so forth. And actually, the home visitation program actually helps not the direct service that the nurse provides, but the linkages they provide to all the variety of services that are particularly tailored to that particular family that are out in the community. And something that oftentimes new families, they start off, they don't know where to go. Something shows up and they're like, well, what am I supposed to do about the kids feeding? And which agency might help me out with that? And so forth. And instead of running into them accidentally, they actually can get plugged into them. So these are very important programs, and there is a great return on investment. And so I certainly want to support this bill. Thank you so much.
Okay, see no other comments or questions? Unfortunately, we still do not have a quorum. I'd like you to close, and upon establishing one, we'll move your bill.
Thank you, Senator. This is a proven prevention model. The bill is received bipartisan support as it's worked its way through the process. I respectfully ask for an aye vote.
Thank you very much. Appreciate your time. We're going to move on to item number 2, AB 176, data collection. Assemblymember Bonta. Good afternoon, Assemblymember.
Thank you, Mr. Chair. Colleagues, AB 176 will address the health and education disparities of ethnic subgroups within the API community. I want to thank the Chair and staff for working with my office on technical amendments to the bill. We are very happy to accept them. Thank you. The API community in California is not homogeneous. Each of our diverse API communities has different social, economic, and educational experiences and outcomes that need to be addressed differently. However, current law only requires state agencies to gather data on a handful of API ethnic groups. The result is that troubling trends in less well-off API subgroups are concealed by higher performing subgroups when data is not disaggregated. This is problematic, for example, among certain Southeast Asian populations who suffer from much lower academic achievement rates than other API groups. AB 176 addresses this data gap by requiring the Department of Healthcare Services, the Department of Managed Care, and our public higher education institutions to use disaggregated categories for each major Asian and Pacific Islander group. The bill also requires those entities to make the data publicly available on their website and in each demographic report released by the institution. The data unveiled by AB 176 will give policymakers, government agencies, and community groups unprecedented access to critical information to more effectively serve the API community and all of our collective constituents. I'd like to introduce witnesses in support of the bill: Kimberly Chen of the California Pan-Ethnic Health Network and Kat New of the Southeast Asian Resource Action Center.
Kimberly Chen with the California Pan-Ethnic Health Network, proud here to support AB 176. Asians are the fastest growing population in the country, and California is home to the highest concentration of Asians and the second highest concentration of Pacific Islanders in the U.S. And our communities share a tremendous amount of similarities, but we also have differences that have impacts on health outcomes. So often aggregated data fails to capture these differences. For example, there are dramatic variations in high blood pressure rates across Asian subgroups, but you wouldn't be able to see that in the aggregate. The aggregate rates of high blood pressure for Asians in California is 20.7%. And 32.9 for Pacific Islanders. But if you break that down, you do see that Japanese Americans actually have a rate of 35.4 and Filipinos with 25.5. Compared that to other groups, you do see that the aggregate does not show the full depth of our communities. And with this information, researchers have been able to identify susceptible populations and find ways to better target their needs. So with this bill, we'll be better able to understand the specific needs of the API population so that we can more effectively drive research and target resources to reduce health disparities. And for those reasons, we're in support and urge aye vote.
Thank you. Anyone else in support?
Good afternoon, Mr. Chair and members. My name is Kat New, and I am the Vice Chair of the Board of the Southeast Asia Resource Action Center, or CRAC. We're pleased to be here in strong support of AB 176. CRAC advocates on behalf of the approximately 1 million Southeast Asian Americans in California, which includes refugee communities from Cambodia, Laos, and Vietnam. As the committee analysis notes, socioeconomic status is a major predictor of health access. The poverty rates of some Southeast Asian American groups are double or more than that of the aggregate Asian American population in California. Additionally, Southeast Asian Americans have a higher rate of individuals with limited English proficiency than California's overall Asian American population. This disaggregated data helps decision makers understand some of the challenges and barriers to accessing health care and to be mindful of other challenges as policies are implemented. Much of what we currently understand of API health disparities is a result of anecdotal evidence as well as smaller studies. For example, studies have shown that Laotian, Samoans, Vietnamese women have the highest incidence of cervical cancer in the U.S. However, many Southeast Asian are unaware of this statistic and they don't go see their physician for their wellness visits. Therefore, they do not receive cervical cancer screening or breast cancer screenings. So collecting this disease and cancer prevalence rates across racial and ethnic groups and making that data publicly accessible can save lives. AB 176 will give policymakers and decision makers more information about the diverse communities that they serve. And we thank the author for introducing this bill, and we urge your aye support.
Thank you. Anyone else in support?
Jasmine Gordon on behalf of the California Black Health Network in support.
Thank you.
Mr. Chair and members, Christopher Castrillo on behalf of the California Faculty Association in support.
Thank you. Anyone else in support, please come up and state your name.
Good afternoon, Chair and members. Michelle Cabrera with SEIU California in strong support.
Mr. Chair and members, Adrian Lopez on behalf of the University of California in support.
Noe Paramo representing California Rural Legal Assistance Foundation in support.
Lema Murtaza on behalf of Asian Americans Advancing Sacramento in strong support.
Billy Sakamoose on behalf of Policy Link, the Alliance for Boys and Men of Color, and the California Equity Leaders Network in support.
Thank you, Mark McDonald McCallum Group on behalf of the Los Angeles and Pasadena area community college districts in support.
Julian Canetti on behalf of the California Asian Pacific Chamber of Commerce in support.
Alex Hawthorne on behalf of March of Dimes in support.
Thank you. Any opposition? Bring it back to the committee. Any questions? Senator Nielsen.
Senator Bott, I want to thank you for the idea here. You have attended many occasions the Asian Pacific and Islander American Public Affairs Association. I'm one of the founders of that organization with Mr. C.C. Yin. We are not a lobby organization, but I can attest that it's the kind of concept that you are embracing here is what is a PAPA purpose. Keep in mind that it's Asian Pacific Islander American Public Affairs Association, and we're in for assimilation, and these bits of information unique to the API community are going to be very helpful in healthcare. But that is as it relates to all healthcare in California. So I'm very supportive. I'd move the bill.
Thank you, Mr. Senator.
Thank you. Seeing no other questions, no opposition, we still don't have a quorum. I'm definitely going to be supporting the bill. Appreciate you bringing it forward. Would you like to close?
I respectfully ask for your aye vote. This bill will help drive policy to address health and educational disparities in an important way, and I thank you for your consideration.
Thank you. So we're going to, item number 3, AB 187, Banta, Medi-Cal Managed Care California Children's Service Program.
Thank you, Mr. Chair. AB 187 is a bill that continues excluding the California Children's Services Program from Medi-Cal managed care until January 1st, 2017. As you know, CCS is a vital program that our most medically vulnerable children with diseases such as hemophilia, congenital heart disease, cerebral palsy, and other severe conditions benefit from. The most recent CCS carve-out is expiring January of 2016. This bill extends the CCS carve-out for 1 year, while DHCS and stakeholders continue discussions on how to make improvements to the program in the future. With me today, I have Tim Shannon and Erin Kelly of the Children's Specialty Care Coalition. I believe only Ms. Kelly will be testifying. And we also have Pip Marks, Program Director of Family Voices, to discuss why this bill is necessary.
Thank you. Please proceed.
Chair members, Tim Shannon, representing the Children's Specialty Care Coalition. I just wanted to introduce our Executive Director, Erin Kelly.
I wanted to start off by thanking the Assembly Member Bonner for his leadership in introducing AB 187. AB 187 would extend the carve-out of specialty health care services from managed care for an additional year. The coalition represents nearly 2,000 pediatric subspecialty physicians statewide who are at the cornerstone of providing care for children with special health care needs. The coalition has appreciated being part of the Department of Health Care Services stakeholder process and shares in the department's goals to enhance the current program. The coalition also shares in the belief of families and other advocates that any reform to the program should be carefully measured and with the primary aim to do no harm to these kids and their respective families. This is particularly important since families in CCS are relatively satisfied with their care now. A recent Title V survey of families statewide found that 90% of survey respondents reported being able to see a pediatric specialist when needed, and CCS families had an overall 86% satisfaction rate. The department recently released its whole child model proposal, which proposes to move 1/3 of the CCS kids into managed care. In its proposal, managed care plans would be responsible for the direct clinical services, care coordination, and service authorizations for a child's specialty care. The timeline is rapid, with enrollment beginning in July 2017 in 19 counties and consideration of expanding implementation to additional counties come 2019. The coalition, along with many other stakeholders, have significant concerns with the department's proposal in its current form and feel that the department's rush to pass this proposal during this legislation session could potentially have unintended consequences to the health and well-being of children enrolled, particularly in the absence of data to demonstrate that moving these kids into managed care will be better or at minimum on par with their care now. In summary, AB 187 would extend the carve-out for another year and allow additional time for the department and the stakeholder community, as well as families, to work together and create the strongest possible foundation for any CCS reform. We respectfully encourage your aye vote. Thank you.
Thank you. Anyone else like to speak in support?
Yes, good afternoon, Mr. Chair and committee members. My name is Pip Marks. Thank you for allowing me to speak to you. I am the manager of Family Voices of California and also the parent of a child who has been using CCS services for many years. I'm here to testify on behalf of families who are asking for the CCS carve-out to be extended for 1 more year. We appreciate the Department of Healthcare Services for including families in the redesigned stakeholder process and for their whole child approach and for the models phased-in process. However, we have really deep concerns for the department's proposal, which would roll our children into a program that is not yet prepared to address their very special needs. Our primary concern is access to care. One of the most important components of CCS is that our children with special healthcare needs have timely access to specialty care. Our children who have very special healthcare needs are very fragile and must be seen and cared for by providers and facilities that best understand their unique conditions. Commercial managed care health plans have a reputation of inadequate provider networks. There is a concern that children with serious CCS medical conditions may not get the access to the appropriate services such as pediatric subspecialists, pediatric therapies, medical equipment, and pediatric habilitation services. The CCS program protects our most vulnerable children from these denials of care. We urge you to please support AB 187 to extend the CCS carve-out for at least one more year so that the department has more time to collect data, do the proper evaluations on current pilots, and use this valuable time to ensure that our children have timely access to specialty providers that they desperately need. We want the department to take more time to be absolutely sure that the protections are in place so that our children come to no harm. Thank you for your time.
Thank you. Anyone else like to speak in support?
Mr. Chair, members, Randy Perry with Aaron Reed and Associates on behalf of the California Children's Hospital Association. Simple bill. We're in the middle of talks, and this program is going to sunset by the end of the year. So we'd like an extension for a year so we can continue our work.
Thank you.
Yes, Mr. Chair and members, Terry Calgar-Hill on behalf of UCSF Children's Hospital at Oakland, as well as the Hemophilia Council of California and the California WIC Association. All of my clients are participating in the CCS redesign process, and we too believe we need at least another year to extend this important program and the carve-out. Thank you.
Thank you. Support?
Yes, Daniel Savino with the Association of Regional Center Agencies. The regional centers, 21 nonprofits charged by the state to coordinate services and supports for over 280,000 Californians with developmental disabilities for the reasons previously stated, very strongly in support.
Kathy Dressler with the Children's Partnership. We're also participating in DHCS whole child concept, but feel we need a little bit more time. We're in support of this bill. Thanks.
Ben Rubin with Children Now, also on behalf of the Children's Defense Fund California, in support.
Jennifer Gabals with the California Association of Health Plans, also in support.
Lydia Bourne representing the California Division American Academy of Pediatrics. We are also in strong support.
Alex Hawthorne on behalf of March of Dimes in support.
Eduardo Martinez on behalf of the California Medical Association would like to align ourselves with the comments of the Children's Specialty Care Coalition.
Tony Anderson, Director of the ARC of California, also representing United Cerebral Palsy in California, in support.
Randy Hicks, Californians for Disability Rights, in strong support.
Any opposition? Okay. Then Assemblyman Bonta, would you like to close? Oh, Senator Pound. And I'll turn this over to the Vice.
Thank you so very much. I want to thank Senator Bonta for his leadership on this important issue, important program. CCS has been around for about, I think, 90 years. So, huh? Since 19.
It's founded in 1927.
Right. So, and the reason the program was created was because when children who have special needs often need many special services, and fortunately, children are generally pretty healthy. So the number of children, or percentage of children, tends to be relatively small compared to the general population, but the needs are very great. And I appreciate that as we are looking at how do we evolve the CCS program, and as our healthcare system, we're implementing ACA and so forth, how we move that forward, that we need to ensure that we continue to have access to care for these kids with special needs. And I just want to draw an example. So, for example, let's just take children with cancer who would be in CCS, right? And just to get an idea of the frequency or infrequency of cancer among children, the most common form of cancer among children, I'm a pediatrician, is actually acute lymphocytic leukemia. So that's the most common oncology problem in children. And statistically, a general pediatrician will diagnose one new case of ALL in their entire career. Now, in training, we spend a lot of time learning so we can recognize it, but it's statistically, that's the most common. And so the challenge is that when we hear about things like narrow networks, network adequacy, often when we've talked about it, we talked in terms of, okay, well, we're trying to save money, so you only, you're not going to be able to choose between, let's say, 5 pulmonologists. We're going to, we have 3 or 2. But when you're talking about pediatrics and pediatric subspecialists, it's not an issue of saying that. I doubt that in a network, if you have in a typical managed care company, which they're going to have not a whole group of, let's say, pediatric pulmonologists or pediatric oncologists. The challenge is if you have a rare cancer, there's probably one in the whole state, and maybe even none in the whole state, and the experts are somewhere else. And so the real question to me is that will the plans and the administration's proposal, at least draft proposal, assure that in whatever system that these children are in, that they will actually have access to the specialists, and we're not just talking about doctor specialists, there's also other, the therapists and so forth, that actually are right for that particular condition, right? And without that assurance, then the CCS program, which is going to fail. I mean, right now, people have access because we have a system which allows to have a disinterested party that's, I think, at the county level who basically does an assessment and then decides this is what you need, and then you get approved for that. And that we need to be sure that that's taking place, that we don't have children who have chronic diseases being shuffled off to people who don't have the experience and the background to take care of them, not because they don't have the board certification and so forth, but that they actually have that particular expertise, especially for really, for rare conditions. And when you're talking about children, most of these conditions are actually relatively rare. But if you're the parent of that child and you're told that, well, actually, the person who actually knows how to take care of this bone cancer is over outside of the area of the managed care company, but we have an oncologist that'll take care of it, but that person doesn't do a lot of bone cancer, that's not right. That's not right. And so whatever system we end up evolving, I think we need to be sure that it provides the protection that the current CCS protection provides, which is they will have access and they will be able to go see that oncologist who actually takes care of that kind of bone cancer or that kind of blood cancer or whatever. And I think without that kind of assurance, then that's not acceptable. So I think that there is going to need more time because this, after all, this program's been around for a long time, but this is not something we should rush. And this is something where there needs to be more time, and I think that's what this bill will do. Clearly, the stakeholder process, I'm glad to know that the department has one, but they need to listen to the stakeholders. I'm going to say that. They need to listen to the stakeholders, so I think what came out does not reflect what I've heard the stakeholders tell me what they are looking for. And so I think we need more time. We need to urge the administration to work with the legislature, work with the stakeholders to craft a system that actually meets the promise that CCS is supposed to provide, which is access to quality care that meets the standards, that assures that I like whole child, but that we have a system of care that actually ensures they meet the needs of each and every child that that's in the CCS program and meets their individual needs as well. So with that, I'd like to strongly support your bill and appreciate your leadership, Senator Bonta.
Thank you, Dr. Pan.
Thank you. We're going to go ahead and establish a quorum. Can we call the members, please?
Hernandez?
Here.
Hernandez here. Nguyen? Here. Nguyen here. Hall?
Here.
Hall here. Mitchell? Monning? Nielsen? Here. Nielsen here. Pan?
Here.
Pan here. Roth? Wolk? Wolk here.
Quorum has been established. Any other questions, comments from any of the members? So I'd like to just make a comment. I agree with, I didn't get to hear all of the Senator Pan's comments, but I do agree with what I heard when I came in. We have a population here that is extremely vulnerable when it comes to the types of conditions that require very specialized health care. The concern I have, and I'm just going to kind of reiterate, not that I'm concerned about the extension, my concern is potentially getting a veto to the extension and being forced into a direction that we may not want to go. Obviously, there's a stakeholder process occurring right now, but I think it's very, very important that the legislature be part of that conversation along with the stakeholders. What I don't want to see is us go down the road that we did with Healthy Families, that we did with the duals, that we've done with Medi-Cal, that, I want to make sure that this segment of the population is protected as well. So, I mean, obviously, I'll be supporting the measure. Would you like to close, Assembly Member?
Thank you, Mr. Chair. This bill is an important measure to ensure that our most medically vulnerable children continue to have access to and receive the specialty care that they rely on, as both of you have just stated. I want to thank staff and the chair and my colleagues for your consideration. I respectfully ask for your aye vote.
Thank you. We're at item number 3, AB 187, due pass to appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Wen. Wen, aye. Hall. Hall, aye. Mitchell. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Wolk. Wolk, aye.
Currently at 7, enough to get out. We have some members who are absent. We'll place that bill on call.
Thank you, Mr. Chair and colleagues.